Assalamualaikum warahmatullahi wabarakatuh, and very good morning to all professors, doctors, fellow colleagues, and audience. Thank you very much, Prof. Sanjeev and Dr. Stanley, for such a great and excellent presentation. So now it's our turn to continue the next topic of lecture for live webinar series episode 6 for this year 2021 in breakfast at FOM. I'm Dr. Suniza, will be moderating our next session of webinar for today. So before we get started, I think let me remind you for all this audience that we will be compiling questions or queries about this topic after the lecture, at the end of the lecture. And please type the question in the Q&A box at the right bottom corner of your screen. According to our National Cancer Registry, breast cancer is the highest number of cancer among women in Malaysia. So women in Malaysia has 1 in 30 lifetime. It means that the 3% population risk in developing breast cancer. The risk is lower than Western countries like UK, 1 in 9 women affected, while in US, 1 in 8 means that 12.4% population risk. So in Malaysia, breast cancer is the most commonly affect Chinese women, 1 in 22, followed by Indian, 1 in 24, and Malay woman in 1 in 35. So as far as breast cancer surgery is concerned, so breast reconstruction post-mastectomy is an oncologically safe procedure that can improve in terms of psychosocial as well as a cosmetics outcome. So the patient's factor, disease factor, and surgeon factor are the 3 main contributing factors in decision of breast cancer surgery. So there is several types of reconstruction have been well developed since years ago to achieve excellent cosmetic outcome. These include the latissimus dorsi flap or LD flap, tram flap or deep inferior epigastric perforator flap or DIEP flap. So for this topic, you may be familiar with delicious 2-in-1 or 3-in-1 coffee mix, which widely available in many countries, in many areas in our countries. But some of you may not be familiar with 2-in-1 breast reconstruction in breast cancer treatment. So by the name itself, we can somewhat figure out that there will be 2 different procedures done at the same setting. So how is it possible to be done for our breast cancer patient? And which patient is suitable in such a procedure? With that, let us invite the expert herself to deliver her talk on feasibility and efficacy of 2-in-1 breast reconstruction in breast cancer treatment during the COVID pandemic era. Please join us in welcoming Associate Professor Dr. Hoong, who is Head of Breast Surgery Unit, the Consultant Breast Oncoplastic Surgeon, Department of Surgery, University Malaya. So I pass this platform to Prof. C. Please welcome Prof. C.
Thanks to Dr. Suniza for the kind introduction. Let me start and share my screen. Okay, good morning, everybody. Today I'm going to introduce you a new, it's not a new technique, but we combine 2 techniques together. Hopefully, so our patient, it shorten a lot of our GA time, all that, and it give still benefit to our patient during this pandemic era. Okay, so I'm Dr. C here, a consultant breast surgeon in UMMC. Okay, so I don't have any disclosure. So this is the outline of my talk today. So we are going to talk about our breast cancer issue here, the problem during COVID era, and the techniques that we started just right before the era as well as extended during the era. And I will introduce the technique step by step, as well as we are looking at the prelim result of the effectiveness and our future on this technique. So let's see our breast cancer statistic, a very short overview. We can see here breast cancer, this is a Global Can 2020 estimation. Breast cancer is the most common cancer for our female, and we have 2.26 million of new cases, as well as 24.5% of all the cancer. And third cause of death, you can see here about 684,000. And we can see the estimation worldwide. The pink color is all country with high breast cancer, like you can have a look incident here. And but very lucky that even though the prevalence and prevalence is very high, but the mortality, we can see here the red color is much lower as compared to the prevalence and incidence. This is because of the new and upcoming latest multiple new treatment that offered to our patient. So what about in Malaysia? We can see these two reports published from 2007 to 2011, as well as to 16, our Malaysia National Cancer Registry. So cancer burden in Malaysia, you can see breast cancer is also the same, highest in Malaysia among the women in Malaysia, and it increased from 31 to 34.1 per 100,000 population from the two reports. And what is the problem of breast cancer treatment during this COVID era? As we know, there will be a delay, because delay can be divided to multi-levels of delay, can be diagnosis delay, time interval to primary treatment delay, delay in surgery, and why it is possible that what happened when during COVID era is because of overwhelming of COVID patient result in inability of our oncological service to run full force because of operating theater inavailability, and we don't have a lack of PPE and lack of extra OT time, and prioritize the surgeries is also very important during this era. And as we know, breast cancer treatment will be considered elective type, right? So it will be the third choices of the, I mean, third uh, uh, level of surgery. So you can see here that's a lot of published paper during the COVID era on what is the best, how to triage our patient, and we can see the immediate reconstruction will be the level C2, and which is over the medium to low priority. So is it going to affect our patient during this era? Can it be if there is a delay in surgery, we don't talk about even immediate reconstruction. Any mortality increase, can it cause more increasing in mortality if we delay our disease and treatment? You can see here the increase in 4 weeks of delay, there will increase in plus 10 deaths. You can see here the worst more than 12 weeks. And what about mastectomy with no immediate reconstruction? It can cause a lot of poor quality of life to our ladies and our patients. So what is a possible solution? Because if we don't do any immediate reconstruction for our young women, you can see they get back pain, they can get spine lordosis and depression as well. So we are looking at any possible fast and safe procedures that we can perform even during the COVID pandemic era, so that we don't jeopardize the oncological outcome, and we also possible to maintain their quality of life. So we are looking at the hybridization of two procedures as compared to doing them separately before this. So what is the advantage of this procedure actually? You can see the adding liposuction, or what we call fat transfer, to our inadequate flap that we always have to accommodate this type of patient, because they do have a very thin at the back of the muscle. Yeah. So the advantages is it save a lot of time and only need one GA setting, and a lot of shorter, and it becomes shorter total duration of procedure if we add on two procedure. Yeah. And there's no increase in complication up to now, and shorter recovery period. They can recover 1 to 2 weeks as compared to more than 4 weeks before that. And the recipient sites is always better uptake during the same setting of injection. And the cost, when we count both procedure separately to hybridize the two procedures, it will be lower. So what is the evidence? So far, we don't have a very strong evidence to combine two procedures together, but as separately, two procedure, if we do separately, it will be, it already have a very good outcome before this. So this is the latest updates that we can see from here. It was published in 2018, yeah. So this is our experience in UMMC. We started the procedure just 6 months before the COVID pandemic era, and we did extended it after the recovery period of the pandemic era. So this is our inclusion and exclusion criteria, and would like to show you what is the procedure like. So first off, we will do a normal marking. This one will add on the leg part because that is our donor side. Then we prepare the instrument, and normally we will do a one setting preparation, and we will inject the area, the harvesting area, and through that we use the cannula to aspirate the fat. Then now we are doing an injection of clean solution with adrenaline, sodium bicarb, as well as lignocaine as well to reduce post-op pain and reduce bleeding from the donor side. And after aspiration of the fat, then we will change the cannula and to start for liposuction procedure. And these two procedures will be done together. Mainly, one team will do the liposuction and the other team will do the mastectomy, nipple sparing mastectomy, remove the lymph nodes that we needed. And once we done both procedure together, patient will be turned to the lateral position, and we will do a harvesting of the LD flap, and a short, probably 30 minutes, you'll turn back the patient for full injection of the fat that we have harvested and processed. And the processing of the fat during the harvesting of the donor side is the same setting. So both team will do together, and we can see here the harvested fat is already sedimented, and once the flap is already transposed, then we will start doing injection, and the other team will do the closure of the wound at the back. Okay, the whole procedure for the initial phase, of course, we started to do the setup, all that. It will take a little bit longer as compared to now. Okay, so we will inject in the fanning out patterns and layer by layer to get the volume that we needed. Okay, so we'd like to increase faster a bit. Then we close the donor side for the fat harvesting area and apply the compression bandage. And another team is doing the closure over the breast as well. So this is the initial result, 1 week post-op and 1 month post-op. Okay. All right. So so we can see here what is our result from the pilot study. So we have done a collection of our cases prospectively from 1st November to 30th November. Total cases of 25, and our mean operating time is 246 minutes, from 330 to drop to 175 minutes. For a total of 3 procedures, we should say mastectomy, sentinel lymph nodes, harvesting of the LD flap, as well as the fat as processing. So the learning curve that we have achieved here among the 25 cases, it came down from 330 down to about 170. You can see here the even though the volume of the breast resected is quite high here, but our learning curve also came down. Yeah. Okay. This is due to the we already used to the procedure how to position the patient, do the cleaning, all that. Yeah. And the type of cases that we have done, 50% is nipple sparing and 50% is a skin sparing. And this is the age group that we have. Normally, those who younger patient will require or prefer have immediate reconstruction during the same setting. And the type of breast cancer, 79% of them is invasive and 21% is ductal carcinoma in situ. So what about the total fat that aspirated? So it's about 400 cc as majority of them, and injected is within 200 to 100 to 300 cc. It depends on the how big is the our donor LD flap that can take up the fat. And this is our complication that we have recorded. So far, there's very mild complication, a small hematoma in one case, infection very minimal in the recipient site, but with oral antibiotics, it resolved. And the seroma is, of course, is the normal type of problem that we have encountered for our LD flap patient, but it doesn't cause too much of problem. We have one superficial or we call partial nipple necrosis, but it healed with dressing. And as well as there is a special case that we have one patient with prolonged wound pain. Okay, so the outcome that we have so far, median follow-up about 13 months, from 2 months to 19 months. There is no local recurrence or distant metastasis. We have assessed early phase of cosmetic as well as a patient-reported outcome. We will show here 3 cases that we have done. The first case, 41 years old lady, came with invasive breast cancer, and we perform a skin sparing because the nipple is quite near, as well as the LD flap and fat transfer. Breast volume that we resected is 660 ml and fat injected is 260. This is a pre-op photo, and following surgery, the recipient area will be a bit swollen, and 6 months after that, it come down, the swelling come down, and then it matched the contralateral size. And our case 13, 49 years old lady with breast ductal carcinoma in situ. So for her, because of the nipple not involved, so we kept the nipple, and we performed LD flap as well as fat transfer. We can see here the resected breast is about 140 ml, and we injected 238 ml for her. And with time, the breast swelling reduced. Then if in 1 year post-op, you can see here it matched back for the contralateral side. The third case, our case 15, a 39 years old ductal carcinoma in situ. So we performed the same procedure, and you can see here pre-op, and we resected 500 ml of breast volume, this breast, and then replaced with our donor fat LD flap, as well as injected 411 ml of fat. So this is 6 months post-op. So the cosmetic outcome that we have for 9 patients from our out of 25 patients, we got about moderate to good cosmetic outcome from them, as well as patient-reported outcome, which is satisfaction. We use Hopewood body image scale, and we can see here the result is comparable. So we are thinking the possible that we can help our ladies probably to shorten their surgery time, and not to cause any long complication, and which can delay their adjuvant treatment post-operatively. And there is a lot of way that we have opted before this. Probably we have a look on the other way, like our tram flap, our implant, and they do have a little bit higher complication and they need a lot of maintenance. And for this case and this procedure, so far we haven't started any redo or repeat surgery or revision, we call it. And patient outcome is comparable, and then safety and feasibility profile has been established so far, but it's a non-randomized type of prospective study. And so far there's no level 1 evidence, but we hope that in future this technique can be more become a more standardized type of technique. And with the expected learning curve, I think the outcome will be more easily to measure, and we could probably make it as a well established and then as well as a very routine type of technique if patient hope for a very simple and despite that still can maintain their cosmetic outcome post-op before they go on for a more distressing adjuvant treatment like chemo, radiotherapy, and so on and so forth. So in conclusion, hybrid fat transfer with LD flap and two-in-one technique is feasible to perform during this era of COVID. And hopefully this shorter procedure can help our cancer patient because it is having an acceptable learning curve, and the low complication which safety profile is quite assured. And we hope that long-term multicentric study can be used to report a better convincing cosmetic and patient-reported outcome in future. So with that, I thank you.
Thank you very much, Prof. C, for very interesting and enlightening talk. But I think so far we don't have any question. Maybe you could answer my question about discussion about this. Is there any difficulty or issue in a mammogram surveillance in such a case? Do you think you have any problem when you managing this patient?
Yeah, up to now, actually, when we do a separate procedure, something like when we put a LD flap and then only another setting, we inject the fat, right? The uptake of the fat is slightly different from the uptake of the fat for this two-in-one procedure. So the one that the first type of injection, in mammogram, we do see a lot of things like breast cysts, the oil cysts, as well as some calcification of the fat that we injected. But so far up to now, when we see our patient, I have reviewed a few patients that we have done this two-in-one procedure. Um, they are very unlikely to have oil cysts one thing, as well as the calcification. So I think this is another thing that we can explore more and see whether this procedure reduce that type of complication as well. Yeah.
Yes, thank you very much, Prosi.
Okay.
Yeah, I think here we are at the end of our webinar. So I hope that it was insightful and interesting. We would like to thank both our speakers, Prof. C and Dr. Stanley, for being part of our webinar today and to share their knowledge in their respective fields of expertise. So our webinar also would not be success without the present all of you. We thank you for valuable contribution throughout the webinar. So lastly, we would like also to thank especially Dr. Shams and University Malaya Faculty of Medicine Visibility Unit for their dedication and hard working in ensuring that our webinar is a success. With that, I thank you.